Hello, good evening, and welcome to our SSA Cross Country Soaring series. My name's Alice Palmer, and I'm filling in for Dave Raleigh tonight as host. He could not be here tonight, but this evening we are welcoming Dr. Quay Snyder, well-known aerospace medicine physician and speaker. And he's also a longtime CFIG and designated pilot examiner. We are looking forward to his talk on physiology for cross-country soaring. We also want to wish him a happy birthday tonight. So as we get started, we are going to pause about halfway to catch up with questions with Quay, and then there'll be a final question and answer series at the very end of the talk. So if you ask a question, just bear with us. We'll catch up halfway or at the end. So thank you, Quay, and looking forward to your talk.
Thank you very much, Alice. Just want to thank everyone, Frank, Alice, Mark, everyone who helped put this together. And also thank you to all the attendees. My talk today is titled Physiology Strategies for Cross-Country Soaring, but in most cases, this is applicable to pilots everywhere. Before I progress, let me just confirm that my screen is being shared appropriately and people can see it.
Looks good, and we can hear you well.
Okay, thank you. Well, let's talk about what we're going to talk about today. Uh, let's see, why is my screen not advancing here? Oh, there we go. Picture of me flying, doing what I enjoy most. If I had my wish on my birthday today, this is what I would be doing, but unfortunately had a little work to do. Our flight plan for today, I'm going to talk about the I'm Safe checklist and overall fitness to fly. And then we'll break down individual elements of that, such as nutrition, hydration, elimination. We'll talk about vision, hypoxia and oxygenation and fatigue. And then we'll have questions at the end for Quay. So what is our role when we're flying? We want to keep aviation safe. Because clearly these guys had in mind when they were playing tennis on the wing of an aircraft. I look at the I'm Safe checklist, and the I'm Safe checklist is useful, but also, are we legal when we're flying? Because we can follow the I'm Safe checklist, but still have challenges with our legality of flying. As a DPE, there are some specific FAA emphasis items for the practical tests we use for gliders. And it says the appropriate use of a checklist, and then a special emphasis item, number 10, is also checklist usage. So the other area of operations that I'm required to test is to look at aeromedical factors. And I selected some of the aeromedical factors, and we'll cover each of those today when we go forward with this. So this is really right out of the practical test standards as well. And I'd like to say that aeromedical decision-making is required for every flight. Talk about FAR 61.53, where we need to make a self-assessment before each flight. But importantly, our self-assessment may change in flight and our status may change too. What I am so glad people are attending here for is that really many of us get relatively minimal training on the physiology and the aeromedical factors that go into flight, both to be safe, but also to optimize your flying. But this is a regular factor in the NTSB and FAA mishap investigations. And there is a specific section in the NTSB reports about the medical aspects of those. So the checklist that most of us are familiar with, it's in the AIM in section 8.8-1-1 is illness, medication, stress, alcohol, fatigue. It used to say emotions, but now the pilot operating handbooks or the pilot's handbooks will say eating and hydration has replaced emotions because emotions are subsumed in the stress element. So I mentioned previously about 6153 operations during medical deficiencies. Many glider pilots and even pilots now flying under Mosaic or light sport do not require a medical certificate, but that does not negate our obligation to be medically sound in our flying. And 6153 emphasizes that if you're going to be a pilot in command or any other crew member, you shouldn't fly if you have a known medical condition or taking medication or treatment that would preclude you from doing all of your required operations. So despite not having a medical certificate, we have the same obligation as any other pilot to ensure that we're safe when we fly. So I ask this question a lot. Rhetorically, I ask people, do they use a checklist when they're going to fly their aircraft? Are they using a checklist on the aircraft? And almost everyone says they do. There's relatively standardized format, and it's required that we do that. But the same is required that we check out ourselves as pilots, because as a human, we're the most likely element to fail in a safe operation. And what's more interesting is that we can fail in subtle ways. It's not like in an aircraft when you get a green light or red light or master caution light that something is wrong. We can perform along a spectrum of wellness to incapacitation. But in many cases, if people aren't attentive to this, they may compromise their performance in very subtle ways and perhaps imperceptible ways. This is from the FAA's checklist on personal minimums. It's a trifold with two sides. And this is one side where it looks at the physical condition. And you can see essentially this follows the I'm safe checklist there. And on the other side, it talks about having your personal minimums and how to use the checklist. And even you see in the small box on the left, making sure you have appropriate clothing or personal needs. And we'll talk about that as we go forward. So this is part of the PAVE checklist that the FAA emphasizes as part of their safety efforts. So let's go into the illness, medication, stress, alcohol, fatigue, and eating and hydration. This is a picture from the Perland project, and certainly they have looked at this very, very carefully to make sure that they perform well on those very, very physiologically challenging flights. So illness. Illness is not just an acute sickness, but you can have a whole host of illnesses, and I've listed a few of the systems that you might have. And people may not think of something beyond just a cold. Certainly if they have certain lung disease or compromised cardiac function, or maybe even have kidney stones. These are all conditions that can arise and can cause compromise in function or possibly even sudden incapacitation. And then you get down to musculoskeletal and you think about being in a glider for 4 or 5 hours and how your back is feeling, et cetera, and whether that will distract you from flying. And then there are other systemic diseases that also affect your cognition. If you're up there for a long period of time, particularly if you have sleep apnea or diabetes and anemia in particular. So the FARs are not particularly helpful. Part 67 only lists 15 disqualifying conditions. But if people go to the Guide for Aviation Medical Examiners, which is open to the public right now, there are hundreds of conditions that require review by the FAA and are potentially disqualifying. So the fact that it's not listed in Part 67 doesn't mean it might be a condition that you shouldn't be flying for, or if you're required to hold the medical, would require review by the FAA before being granted that medical certificate or special issuance authorization. So we've talked about illness. Let's talk about medications. And medications can be in the form of illicit substances or prescribed substances. But this was for 10 years, it was on the the NTSB's most wanted list from 2015 through 2024 as one of their 10 most wanted items to address to improve safety. So let's talk about medications. There are many medications that are okay to take and fly. And frequently in our office, when we get asked by pilots, can I take this medication and fly? The answer is not yes or no. The answer is, what are you taking this medicine for? Because it could be a perfectly permittable medication, but the underlying condition might be disqualifying, such as a decongestant for someone with a cold. Well, if you have to take a decongestant because of your cold, the cold itself would be disqualifying. Any medication you're taking and flying should be ground tested beforehand. And you can check with your AME or the database that I'll point out to you shortly about whether that medication is allowed. But again, it's always the underlying condition. And medications that cause cognitive impairment are always disqualifying. And the most common one you see down on the bottom is diphenhydramine, otherwise known as Benadryl, or any of the PM or nighttime type medicines generally have diphenhydramine or one of the related antihistamines, which can have cognitive impairment. In particular, diphenhydramine is restricted from, or people taking diphenhydramine are restricted from flying for 60 hours, 2.5 days after a single dose, because of the cognitive impairment that it causes with a long half-life. And although marijuana is allowed in some states, it is federally prohibited right now. And as pilots, we fly under federal law. So this is not an allowed medication that we can take. Medication, either medication or recreational type thing. Stay away from that. The NTSB looked at medications in fatal general aviation accidents, and they did 2 studies, one that took them through 2012 and one that was extended. And what you see here is a steady rise, despite the advertising that the FAA gave, in use of medications that potentially are impairing or definitely impairing for flight safety. So up to 40% of fatal GA accidents, the pilot in command had the presence of either potentially or definitely impairing medications on board. And this is breaking down those same statistics by age group. And what you see is, as we get older, we're using more drugs, but our use of potentially impairing drugs and other substances are rising. The only thing that doesn't rise is illicit drugs. But sailplane pilots tend to be in an older age cohort, and just recognize that the medications we're taking may have an adverse role in safety. So please ground test, check with your AME, make sure that the medications are safe and legal to fly with. And in the NTSB safety study, I've highlighted on the left medications that are potentially cognitively impairing. And you can see they make up a significant amount of the total medications that were found on board on the autopsies and drug studies afterwards. So just to refresh you, we do have an obligation under 6153. The key issue is not only the medication, but what is the underlying condition. The FAA currently publishes a do not fly, do not issue list. I've put the URL for the in the Guide to Aviation Medical Examiners. And we heard on the AME grand rounds yesterday that the FAA is going to publish additional information regarding specific conditions and medications. Additionally, I've put the brochures that the FAA has on their safety brochures, which you can download for free, regarding medications and flying. So each of those three are out there. Also, I'm not advertising our services, but on our webpage at aviationmedicine.com, we have a medication database with the FAA policy on over 800 medications. It's free to everyone, so feel free to look at that or check with your AME. And when the FAA publishes their information too, that would be the primary resource to go to. So we've talked about illness and medications. Let's move on to stress. There are lots of distractions that you can have that will potentially detract from your safe flying. And I've listed some of those. But when pilots ask me a question and they've told me their story about what's going on in their life, how it might have disrupted their sleep or their eating, etc., my question to them when they ask me, should I fly or not, is, would you put your family in an aircraft that's piloted by a single pilot with the story you just told me? And if you can unequivocally say yes, then you're probably okay to fly. But if all of these thoughts are intruding while you're flying and you should be doing checklist or have your situational awareness, then you are probably not safe to fly and would be better sitting on the ground until you can get some of this either resolved or under control so that you can concentrate fully on your flying. Mental health has been a big source of interest to the FAA and indeed around the world. There was the pilot fitness arc in 2015, where we looked at issues after the German wings and talked about different ways that we could improve mental health. And then the FAA had another aviation rulemaking committee in 2024 called the Mental Health and Aviation Medical Clearance Act, where we looked at barriers and recommendations and identified 7 barriers and 24 specific recommendations. The NTSB also had a mental health and aviation summit, and Chairman Hamady has repeatedly talked about the role of improving mental health and removing barriers to pilots seeking help. A lot of organizations around the world are also looking at ways to improve this. Excuse me. So really quite a significant issue and recognized as impairing for flying if it gets to certain degrees. And many pilots who hold medical certificates are reluctant to get mental health help because they fear it will jeopardize their medical certificate. The FAA has actually made 11 mental health conditions, which are listed in the Guide to Aviation Medical Examiners, as those conditions with appropriate documentation that the AME can issue a certificate and people continue to fly. Plus, there are a subset of people who are on medications and can fly and can continue to fly or fly under a special issuance. Mostly under a special issuance authorization. And we're working on projects on this right now to increase the latitude of mental health treatments that people would be allowed to fly with. Depression is really common. Up to 50% of us will have it sometime in our lifetime, and about 20% per year will meet the criteria for a depressive disorder. And there are lots of things that can cause that. I've listed some of the intrinsic and extrinsic provocateurs for that. But depression is a diagnosis, but people can have depressed mood, which is not depression. And so that would be on the mild end of the spectrum. And certainly the severe end of the spectrum would be suicidal or homicidal type ideation. But in any case, that whole spectrum can reduce our cognitive ability primarily because of sleep loss due to the anxiety or whatever we're experiencing, the fatigue that goes along with it, and the impaired cognition. And what we see with a lot of mental health conditions, if cognitive testing is done, once that condition is successfully treated, and it might be with just talk therapy, we see a distinct improvement in cognitive function. So it is a high interest item. I've listed different resources that the FAA has here, and these slides will be available by PDF for the people who have attended afterwards. And there will be the links to these different information pieces that the FAA has put out. I would recommend that people go to the Guide for Aviation Medical Examiner. These are the 11 diagnoses that currently an AME is authorized to issue a medical certificate if a pilot has one of these conditions that's adequately treated and has the appropriate documentation. So you see there's a wide spectrum of things that you don't have to worry about losing your medical certificate if you're a pilot that's required to hold one. So moving to the next one, alcohol. I would say alcohol and intoxicants because I would also include some illicit drugs and tetrahydrocannabinol or cannabis in that group. But overwhelmingly, the drug of choice used by pilots is alcohol. Of our pilots in the HIMSS program, about 92% alcohol was their primary drug of choice. A recent study from the National Health Survey, it was a little surprising that only 54% of US adults consumed alcohol in the last 12 months. That was down from about 7 years ago of 65%. The FAA has a brochure on alcohol and flying. The statistics in the US are that 7 to 9% of us will have an alcohol use disorder. And when you throw in the drugs, which is actually more people have a substance use disorder, not alcohol, than alcohol. But the sum of that is about 15%. So just because we have a pilot certificate or if we hold a medical certificate doesn't make us exempt from these conditions any more than it makes us exempt from cancer, heart disease, or diabetes. And in 2023, a quarter of the US population was using cannabis in some form. So what are the adverse effects of alcohol? Well, the hangover, dehydration, potential cell dropout on that, but definitely cognitive impairment. And for people who are heavy consumers of alcohol, the cognitive impairment can last substantially longer than the alcohol in the blood. So you can have a blood alcohol level of 0.0 and still have cognitive impairment as a result of that. Also, alcohol is frequently used as to help people go to sleep or before they go to sleep. And indeed, it is a very effective sedative type thing, but it destroys your REM sleep. And the REM sleep is absolutely critical in cognition, in memory formation, and learning. And there's a number of diseases that can also occur as a secondary to excessive alcohol use. I'll just point out the HIMSS program, which is the certification program for pilots with alcohol and substance use disorders after they've been treated and returned. Currently, the FAA has returned over 13,000 pilots with substance use disorders back to flying over the history of the HIMSS program. So let's move to fatigue. Here's the ICAO definition of fatigue, which really stresses the reduced mental or physical performance capacity. And it attributes it to just three things: sleep loss or extended wakefulness, which would be acute fatigue, circadian, or workload. But actually, there are more causes of fatigue. So I believe the ICAO definition is incomplete. But before, let's just talk about the heroic flight of Charles Lindbergh. His flight was 33 and a half hours. He was up for almost 56 hours by the time he landed and finally got to sleep. But this was a quote from his autobiography, when he was over the mid-Atlantic there. And he's talking about one eye would, he was trying to let one eyelid close at a time and prop the other, but it was too much. Sleep is winning. My whole body argues dully that nothing life can attain is quite so desirable as sleep. And the more research I do on this, the more I try to get 8 hours of sleep every night because I realize how important it is. So fatigue can come from many reasons. The acute short-term deprivation of sleep, and generally people can recover in a couple of days. The chronic long-term, people who feel that they can get by on 6 hours of sleep a night and do that on a regular basis, are really fooling themselves and is associated with increased rates of morbidity and mortality. Certainly, those of us who travel across the globe have experienced circadian desynchrony, or people who have to work backside of the clock, like a lot of our nurses or firefighters, first responders, experience circadian fatigue. But there are a host of medical factors that can also contribute to fatigue. And so traditionally, people think about the top five up there, that time on task, total time awake, how much sleep you had before you're flying, your circadian, and also the workload. Different workloads, there can be boredom and monotony, or there can be very high workloads. But I'm going to talk about other factors today too, such as environmental conditions, which can greatly affect fatigue acutely. And as I said right at the beginning, when you're looking at what your status is and the I'm safe and how individuals fail. We fail along a spectrum, but we can move quickly along that spectrum. So if you're good when you're taking off, but you're on a hot day and you're flying for a long period of time and the sun is in your eyes, that'll have a deleterious effect on your fatigue at that point and your cognition too. And we've already addressed medications and potential hangovers there, the stress part, and we'll talk about some of the physiologic factors as well. So this is from the NTSB again, and this was a study by Miller at specific issues that arose that compromised safety in aviation as a result of fatigue. I teach a class on this and show for each of these bullets that I have here, I show one fatal Part 121 type accident associated with each one of these type conditions. So these are conditions with a two-pilot crew with certain rest requirements, the redundancy, all the technology, and they still have fatal mishaps as a result of fatigue with these things going on. But you think of us as sailplane pilots, single pilot without a lot of the automation, the redundancy, et cetera. And so those effects are all accentuated quite a bit. So here's the bottom line. Fatigue impairs your cognition. Fatigue makes you stupid. And there's different strategies for that. We'll go through it briefly. Our body temperature goes down by about 3 degrees Fahrenheit to sleep. So you make the bedroom cool. Ideally, get it down to 68. I'll go down to 65. Keep it quiet because noise actually is louder when you're trying to sleep or when you're under the influences of a sedative like alcohol, because the muscles in your ear that serve as shock absorbers on the tympanic membrane, the eardrum, actually relax. So noise is louder when you're trying to get to sleep or you have sedatives on board. Dark, we can talk ad infinitum about the role that light plays in suppressing melatonin. Also, people who have a pre-sleep routine, who do the same thing every time, is essentially like a Pavlovian response where you go through the routine and your body's ready to go to sleep. There are also some specific behaviors that you can take. Avoiding alcohol. Again, alcohol will make you get sleepy, but it destroys the REM sleep. Caffeine has about a 4 to 5 hour half-life, and it suppresses the brain's uptake of a chemical called adenosine, which triggers the sleep drive. Essentially, caffeine blocks that receptor in the brain. So caffeine later in the day is to be avoided. I recognize there are some people who can take caffeine and not be affected by it, but that's in a minority. Blue light, particularly at the 460 nanometer wavelength, which is kind of like the blue of the sky, suppresses melatonin. A light protein snack will help, and we'll talk more about that in the dieting. And then a short hot shower. Again, you want to be cool, so a short hot shower will cause the capillaries in your skin to dilate, and you will be shedding heat there. If you take a cold shower, you're actually constricting those capillaries and you're moving heat into the core of your body, so your core body temperature rises. And if you stand in a hot shower too long, your core body temperature will go up. So all of those would adversely affect the desired drop in core body temperature associated with sleep. You can talk about all the different things you can take. You can take caffeine, you can take no-dose, you can take amphetamines, but that's all just masking the fatigue. And there's only one cure for fatigue, and that is sleep. So let's briefly move on to eating and hydration and what you can do not only for your health, but also to keep you cognitively at your prime while you're eating. While you're flying. So as far as the timing of your food, the idea is you want to maintain a stable blood sugar. So to do that, you want to avoid the simple sugars. So the old thing we used to do in the Air Force, the fighter pilot breakfast, a Coke and a candy bar, kick the tires and light the fire, was absolutely the worst thing to do. And if I knew then what I know now, I never would have done that. But if you keep a stable blood sugar, you avoid these spikes in your blood sugar and subsequent spikes in the insulin level, which drives down your blood sugar. And that's really where you get the compromised function. So to do that, proteins are absorbed slowly and don't cause the spikes, as are complex carbohydrates, not the simple ones. You want to have adequate calories, but not a whole lot, because if your body is trying to digest a high caloric load, again, that diverts blood away from other organs, in particular the brain, and can also make you fatigued. So a grazing strategy would be most appropriate. When you're in the glider, most of you who have flown cross country have already figured this one out, but you want to take some food with you that can sustain you, particularly if you're having long flights. So I listed a few. The string cheese has the protein and has some fats that's slowly absorbed. Some of the sports bars, as long as they don't crumble and they're not high in sugar, are good. Some fruits, plus or minus on the fruits, they do have sugar, but because of all the fiber, they're absorbed rather slowly, but they can be a little bit messy in flight. And then also you want something that is easy to open. So for the string cheese that I get, I will make sure that I open those plastic ends of that before I go up in flight, and then keep them in a leg pocket or thigh pocket of like cargo shorts or cargo pants, so I can access them easily when I'm flying. We'll talk about hydration here in a second. Actually, I'll talk about it now. So these are the basic needs for hydration. Essentially, these are your baseline needs. These are not the increased needs you have because you're in the sun, you're in a dry environment like Colorado. It's a hot environment, so you're sweating more. So men need about a gallon a day baseline, and women need about 3 quarts a day. But traditionally, what we see in the US population is that we're deficient even in our baseline hydration. So let's make sure we increase that, and we'll talk about strategies for that. If you're thirsty, you're already a leader behind, and it's essential that you catch up as quickly as possible. If you have a relief system in the aircraft where you can see your urine, or you're going to urinate just prior to flying, make sure your urine is light yellow to clear to know that you're well hydrated. Alcohol and caffeine are diuretics. So diuretics mean they cause a fluid loss. So even though you're ingesting alcohol, which you shouldn't be before you're flying anyway, but coffee, you're going to you'll have a net loss of water rather than the intake. The sports drinks, I think, are particularly useful if they have low or no sugar, but essentially have an electrolyte mixture. Low sugar is okay as long as you're ingesting them, but you don't want to get something with a lot of sugar that will spike your blood sugar and go back. But the electrolyte replacement is essential in that. I personally use 3 Camelbacks when I'm going, and the Camelbacks work much better than a fixed bottle because of the pressure changes when you're flying. Um, 2 of my Camelbacks have an electrolyte solution in. One is kind of a Gatorade-like one. One is just pure electrolyte without sugar, and then I have one with pure water as well. And importantly, you need a relief system. Um, if you are restricting your fluid intake because you don't have an adequate relief system in your aircraft, you're making yourself dehydrated. So it's important to have a relief system, have it set up before you go so that you can remain adequately hydrated without getting uncomfortable, without soiling your parachute, or without returning early because your relief system is non-existent or non-functional. So elimination too. Most of us know that we want to make sure that our bowels are as empty as possible before we go up and fly. So some things to avoid would be a high fiber diet, although it's probably good for your long-term health. It's probably not good for helping you if you're going on a long flight. But with the decrease in barometric pressure at 18,000 feet, our GI volume is double from that which we have on the ground. So you do have an expansion of your gut, and you need to make sure that you can relieve that adequately. Regarding the urine and elimination systems, there are 2 articles in Soaring magazine that I referenced there, which are excellent articles and talk about the variety of relief systems that are available. And I've listed 5 different options down there below. So thermal comfort. Again, flying here in Colorado, we're flying at much higher altitudes than our brothers and sisters are that are flying down in the Florida area or at lower altitudes. But the temperature with the dry adiabatic lapse rate is dropping 5.5 degrees for every 1,000 feet you go up, with the moist adiabat about half that. So you can have 80 degrees Fahrenheit on the ground, and on a dry day, if you're going up from, let's say, 7,000 to 17,000 feet, you have experienced a significant drop, almost a 50-degree drop in temperature. So you need to make sure that you're not overheating on the ground, but you're not getting too cold in the air. So a technique for that is using layered clothing. You can have clothing with zippers or Velcro that you can ventilate or close up. I talk about the cargo pilots more for the food and accessing food that you have there. Gloves, beanies, whatever you want to keep your hands and feet warm, particularly if you're going up particularly high altitude. But you can manipulate the controls with. And then, of course, UV protection, both for your skin and your eyes while you're up there. Okay. And then one strategy that most of us have used when you're cold, try to get into the sunshine and warm up a little bit. And when you're too hot, fly under the clouds and cool off a little bit so you can use the sunshine to help you with your thermal regulation. Let me talk briefly about cognition. This is a chart from the Naval Aerospace Medical Institute, and they looked at cohorts of pilots by age, and you can see horizontally on the bottom the different um, age cohorts. And hopefully people can see my mouse here. But you see, as we get older, we have a steady decline in our cognitive function. But the good news is those people who take care of themselves, and this is the 80 to 85-year-old cohort right here, the oldest cohort that they checked. And if you go across, essentially they're functioning about the same cognitively as a young, healthy person, a normal young, healthy person. But the potential for deterioration is significant. So this is my plea to you is do all you can to optimize your health through a series of strategies that we'll talk about a little bit later so that you can continue to perform at an acceptable cognitive level. So kind of looking at the cognitive function, my mom didn't have advanced degrees, but she had a lot of good insight. And I think that all of these would be ways to keep you on the upper part of that curve that I just showed you. With sleep, science is solid. You need 7+ hours of sleep per night. Um, don't smoke, and I can go through a host of things, particularly when you're flying, how the carbon monoxide in cigarette smoke binds to the hemoglobin and essentially creates a relative hypoxia because the hemoglobin can't carry the oxygen because it's bound up by the carbon monoxide. So someone who's a 2-pack per day smoker for about 10 years will have a significant portion of their hemoglobin bound up. And so roughly, I mean, this isn't exact, but roughly at sea level, they would be getting about the same amount of oxygen to their brain as someone who didn't smoke around 10,000 feet. Minimize the alcohol. The alcohol has the cognitive and deterioration and the impairment with REM sleep. Regular physical activity, the current recommendations are 150 minutes per week at any intensity, sometimes moderate intensity. But if you want to increase your VO2 max or your potential oxygen utilization ability, a short burst of anaerobic activity. So as hard as you can go for 20 seconds at a time, 3 times a day for 2 or 3 days a week may increase the VO2 max. But any exercise is good. And if you look at 150 minutes a week, that's 20 minutes a day to get out and walk. I've already talked about a healthy diet, avoiding the simple sugars, limiting the salt intake for blood pressure uses, but I'll put an asterisk by that. If you're going to be flying for long periods of time, you want to make sure you have adequate salt in there because salt will pull fluid into your system and help you with the hydration. Adequate protein, current recommendations are a minimum of 1 gram per kilogram. I think a lot of people would push that up higher up to about 1.6 milligrams per kilogram, or almost a gram per pound of body weight per day. And then challenging yourself mentally. Again, those people in that NAMI study of cognitive function, the people, not only in the NAMI study, but in other ones, we're looking at those people who were on a continuous path of learning, cognitively functioned at a much better level. And although it's not completely protective against all types of dementia, Alzheimer being the most well known, it can reduce the progression of mild cognitive impairment. And there are different apps that you can use. They're out there. I listed a couple of them that are cognitive training type programs. Other things you can do is a recurrent aircraft training. You all are here on a wings program right now. I can't emphasize enough Professional pilots do recurrent training every 6 or 9 or 12 months all the time, even though they have all these protections. As glider pilots, we need to make sure that we're doing recurrent training and we're not just filling squares. We're out there getting a careful evaluation of what our current skills are and looking to improve our skills. And we can do that by maintaining currency, but also my plug for flying on a regular basis with a CFI, just to point out areas that you can improve on. In fact, this weekend I flew with a wonderful CFI who had great recommendations for me too. And even after 51 years of teaching, I can still improve every time I go up. There's always something to get better, and he helped me do that. So we looked at some of the other things that help with cognition, with sleep, and also with mental health. And it's been shown that some sort of cognitive relaxation technique, be it meditation, mindfulness, spirituality, prayer, box breathing, parasympathetic training, etc., all will help reduce the mental stress that people are having and improve mood. And ironically, out of one study in the in the UK, they showed that people who were engaged in this, along with social connections, had a substantial reduction in early mortality, more so than reducing cigarette smoking and changing the diet with respect to fats. And that was a surprising study for me, but it was 69,000 people in that study. So let's go back to the bottom line here. Should I fly? Well, as I said at the beginning, if you did an honest assessment of yourself using the I'm safe checklist or whatever other checklist you use, if you could say that I would fly with a pilot who's in the same condition as I am, you're probably okay. If you have to take a medication to fly to get you up, and so I'm not talking about regular medicines that might be prescribed for your blood pressure or your cholesterol. But if you have to take a medication acutely to fly, you shouldn't fly because the underlying condition will compromise you. And make sure you've prepared yourself as well as you've prepared and checked your aircraft. So it's not only, yeah, I think I'm good to go, but can you handle the in-flight emergencies and the planned flight that you're doing based on your physical, your emotional, and your cognitive function the day that you go up for the flight? So my bottom line on this, just a quick one, and we'll talk about some of these elements a little later. Take care of your health so that maximizes your performance both physically and cognitively. Don't fly when you're sick. Don't take medications that make you cognitively impaired. If you need help, particularly in the mental health world, ask for help early, get it early. Is much easier to handle when the disease or the impairment process is minor versus allowing it to get more severe. Minimize your intake of alcohol and don't use illicit drugs. Make sure you get enough sleep, proper hydration, and we'll talk a lot more about oxygen beforehand. But make sure you're using that I'm safe checklist before every time you fly. Here are a couple of resources that are available from the FAA. These are the Airman's Information Manual, and these are the various sections they have. Much of what I've talked about has been drawn from this resource. And with that, I think I'd like to give us a little break from me talking. That's a flight where apparently I was cooling off a little bit. But Alice, can you can give our participants an opportunity to ask questions?
Yes, we've got a couple of questions for you right now. First question is, please expand on having heart valve replacement as a disqualifier.
So we're getting into the medical certification issues, but the FAA will allow pilots to fly with heart valve replacements. They even clear pilots to fly with heart transplants. But there are different protocols depending on the type of valve you have and what medications you need to be on it and what the underlying cause and whether there's comorbidities associated with, such as a dilated aorta. But in most cases, pilots with a heart valve replacement who've been adequately treated can return to fly with special issuance certification. And we've gotten hundreds of pilots cleared with valve replacements or valve repairs. The waiting period for a valve replacement is 6 months. With valve repairs, certain valve repairs, it's only 3 months after the repair before you can be cleared to go back and fly.
Okay, thank you. The next question by Doug is, I find camelbacks to be very irritating because they don't send enough liquid fast enough, or they require too much sucking. Is there a fast flow valve solution for camelbacks?
I use the valves that have the twist knob on it that opens and closes, and they seem to work better. And the other thing is when they do get empty, they can, or near empty, they can be a little difficult, but you need to make sure you arrange it. So in my glider, I make sure that the hose that connects to the camelback itself is in the lowest position because that's where it uh, derives from. And then I close off the valve before I'm done sucking on it so that the water stays in the tubing. The alternative solution, which I also adopt, is I have that little shelf behind me, at least on my glider, and I can stick the camelbacks up on that shelf, and then they're above me. But I still need to make sure that the attachment for the hose is in the lowest portion. So make sure it's not flipped upside down when you do it. But yes, the bite valves that you use and open up, those are problematic, and I got rid of all of those.
Okay, Brian asks, what steps do you take to minimize the adverse effect in our soaring operations of exposure to high heat on the ground portion of the flight?
So there are a number of steps you can take. One, you can stay in the clubhouse as long as you can. You can prep your glider the day before or early in the morning, so you're not trying to assemble your glider in the middle of the day. You can use light reflective clothing with a hat that will minimize the heat absorption. If you're out there on the line waiting for a tow plane, you can be under the wing in the shadow of that. Um, Cooling is another option. You can take, at times I've taken a frozen water bottle that I've frozen overnight and just keep that, and I'll put it on my forehead. That there are three parts of your body that they have the ability of the capillaries to shut down and divert blood to different areas. They're called the glabellus part of your body, and those are the ones that will never grow hair, and that is your forehead, your palms, and soles. So if you can get your palms cold or your forehead cold, by holding on to something icy, you're actually lowering your core body temperature in that situation. And then ultimately you can, if you want, although it's inconvenient, you can put water on different parts of your body or use water with a headband. And uh, the body cools at a much more rapid rate if there's wind over a wet surface area, such as your body. And when I do athletic competitions, by being wet all over with the wind, although you can't really take advantage of that while you're in the glider.
Okay, great. Thank you. That's it for questions right now.
Okay, I can move on to the next section if you like. Let me just get a quick drink of water so I stay hydrated. Okay, so next we're going to talk about vision here. How to scan optimally while you're in the air to make sure you can clear, because one of our biggest hazards when we're flying, besides on tow and the landing, is midair collision. So let's talk about how we can do that. So clearing, we all know we're supposed to clear, but unless you have a good technique of clearing, you're eyes will be potentially ineffective. So our best visual acuity is in the central 5 to 15 degrees of our vision. That's where we can detect specific objects. As we move out peripherally, even a little bit outside of that 15-degree cone, our best visual acuity is 20/40, and it deteriorates more to the periphery to about 2200. But the periphery has a great benefit in that it is much more sensitive to motion. So the scanning technique that you need to use or should use is select a 15-degree sector of the sky. Ideally, at your level, but you can move it around. Hold that sector for 3 to 5 seconds and specifically look for an object. If you see an object, then you can avoid it. But also by looking specifically in that sector, your peripheral vision will pick up movement. And if you do pick up movement, then you can swing your eyes immediately over to that area where you picked up the movement, and then put that in your central 5 to 15 degrees so your best visual acuity can detect that. And then after you've scanned the lateral areas, move back to the front. Okay. The horizon is the most important part to scan, but aircraft descending from above or ascending from below are also factors. So a good scanning technique is forward for 3 to 5 seconds, and then switch over to 20 degrees to the right, 3 to 5 seconds, go back to central, 3 to 5 degrees to the left, and use a repeating pattern like that where you're going back to your straight ahead to take advantage of, one, your best visual acuity, but two, motion. The worst thing you can do is sweep your eyes across the horizon because you don't get the best visual acuity and you don't get motion detection. So do not sweep your eyes, focus on a particular segment, and then move on from that segment after 3 to 5 seconds. Okay, your visual acuity is best in bright light. In your contrast sensitivity, so the ability to detect something and to detect it as different from the background is reduced under clouds. So some people can use the yellow colored lenses, which can increase contrast sensitivity by filtering out the blue light. Also, if you're glancing at the sun, you can get a temporary flash blindness. You can get it from other causes too, but the sun is far and away the most likely. Remember that hypoxia substantially reduces your color vision first and your visual acuity as well. Any of you who have been in altitude chamber training in the military know that as you go up and they put those cards in front of you that are colored and you go to higher altitudes, you don't notice the color deteriorating, but as soon as they tell you to put on your oxygen mask, it comes on like Technicolor. So that's very substantial. Hypoxia also reduces your acuity. And so that's why the military essentially requires that you be on oxygen at 10,000 feet and above, and at nighttime, 5,000 feet and above, because of the reduction in visual acuity. And for us old people, we have other problems too. We have early cataracts. And cataracts depend on the location. They can be in your central vision, and usually people will notice that, particularly at night, because you'll get glare and flare and halos at night, and that's a cataract in your central vision. That deserves to be treated, and there are different types of intraocular lenses that can be implanted right now, which has people can return to fly fairly quickly, depending on what type of lens they get. Within a week, if it's a monovision, a single vision type cataract. If you have peripheral cataracts, usually not a problem in bright daylight because your pupil constricts and the light isn't necessarily going through the peripheral areas of your lens. But as it gets darker at night, that becomes more of a problem. And then presbyopia, that's your arms aren't long enough to read, or the instrument panel's not far enough to read, or you can't read your charts. The color intensity is going down. So you need to make sure that you have appropriate spectacles if that's what you're using, to make sure you can read the instruments as well as see well at distance. And for a couple of years, I was in that Never Never land where my instruments were just blurry enough. And then finally, I found some lenses that now I can read the instruments sharply and also see at distance sharply. So sunglasses. Sunglasses are good, but they can be bad too. Overall, they're good because they reduce the eye strain and can reduce fatigue. But you want a neutral color and non-polarized. Problem with polarized is that two things. One, some of the instruments are actually polarized, and if you don't have your glasses lined up with the polarization of the glass cover of the instruments essentially disappear. But also, you miss the wing flashes. If another glider is out there and reflecting the sunlight, the polarized light will reduce that, which is what it's designed to do. But many cases, detecting a sailplane, if you're not using your FLARM or ADS-B, comes from seeing that wing flash in the sun. Ideally, gradations of the neutral colored sunglasses would be ideal so that the sun coming from above is blocked more, but you can read the instruments more easily with the lighter shading down below. These glasses look pretty cool, but they're not blocking the peripheral entry of light. So in certain conditions, if the sun is 90 degrees off from you, it can still cause a certain strain from there. A lot of times we're perspiring fairly heavily when we're flying in the glider. So something that either has an absorptive thing on the top of the frame or something that gives you some distance from the top of the frame and the lenses from your forehead. And when I say some distance, I'm talking about a millimeter or two, just so that the sweat isn't dropping on your glasses and interfering with it. UV blocking is a great idea. You'd like to reduce the UV strain, which can increase your risk of cataracts too, and we're outside a lot. So most glasses and even the plastic lenses now have a significant UV blocking in that. You can also get glasses that reduce the light. So you can get some with 15% reduction all the way up to about 45% reduction. Be careful with those that reduce the light by a great deal because if you're flying under a cloud and the light isn't there, it may decrease your visual acuity. If you do have problems with your glasses, make sure you can remove them easily. So having the little neck gaiter that you have around is probably an easy way to do it without losing them if you need to put them back on, such as you're flying through a cloudy day and then you go through a segment of bright sunlight, you may need to put them on. And bifocals and progressives to address the presbyopia is another useful thing for us folks who are a little bit older and are suffering from presbyopia. I've already talked about the non-polarized lenses and the reason to use non-polarized lenses because you do want to be able to pick up a wing flash when you're there. Ideally, if you can have the sun behind you when you're flying, I know that's not always possible, or possibly if you're flying a triangle, possible only 1/3 of the time, depending on what time of day it is. But that helps with the acuity because it lights things up in front of you. In a low contrast situation, remove the sunglasses unless you're using the yellow tinted ones. So situations that would reduce your contrast sensitivity and your visual or your ability to pick up things would be under clouds or in your haze or rain, smoke, smog, or flights late in the, just prior to sunset. Some people have problems with the low humidity and dryness, particularly here in the Colorado area. So blinking will help. Closing the air vents will also help. If you are perspiring, 2, you can have the lint-free wipes available in the cockpit, very similar to what we clean our cockpits with. Clean our canopies with. And the FAA has a safety brochure on sunglasses selection for pilots, and much of what I have in this presentation came from that safety brochure. So let's move on to hypoxia and oxygen here. We'll talk about different parts of it. I'm going to go through it rather quickly so I make sure that I have time for questions, but I do want to spend a little bit of time on this because this is very significant for our ability to perform well, to have the appropriate cognition, to have the appropriate visual acuity, and physical performance. So we're going to go through these different areas here. A little bit of history here. Father Acosta was the first person who really talked about hypoxia with going up in altitude, and here's his quote. There's no doubt that the cause of this distress and strange affliction is the wind or air current there. It was up on a mountain. I'm convinced that the element of the air in this place is so thin and so delicate that it's not proportioned to human breathing, which requires extensive and more temperate air. So think about being on the top of Pikes Peak as we fly over them and all those people are waving to you. So the first researchers in this area were Glasher and Coxwell. And in Civil War time, they did a balloon ascent and they went up fairly high. I mean, they were over 30,000 feet. And they noticed and were taking notes as they were ascending. And so they said that the hands and lips were blue. That's the cyanosis we did. The visual acuity, they couldn't read the instruments because they were hypoxic. And then Glasher lost consciousness for 7 minutes, and Coxwell saved them by pulling the balloon cord with his teeth and descended from 9,400 meters. And then the father of aerospace physiology was Paul Baer, and he has a quote here. The numerous data have shown that very clearly the decompression are not due to the lessening of atmospheric pressure, but the diminution of oxygen tension, which actually is related to the oxygen pressure, but it doesn't get into the blood. So he described this very, very accurately, other than the diminution of the tension of the oxygen is related to the reduced pressure of the air. So he designed an altitude chamber and published a paper on this. Actually, it was a book on this. And he predicted that an oxygen tension of 45 millimeters was the limits of life. Normally were right around 1,000 plus or minus. He described altitude sickness, decompression sickness, and also oxygen toxicity. It's possible to get too much oxygen, but not in the situations we're talking about. So here was a group that tried to break Glasher and Coxwell's record of 9,450 meters. And they actually trained in Paul Baer's chamber. And their observations were the chamber wasn't cold enough to replicate going up in the air. Again, the adiabatic collapse rate. That they couldn't be active enough because at that time, the only thing they could ascend in was a balloon and required some activity. And that the chamber went up and descended too fast. So they did their own balloon flight in 1875, but they didn't have enough supplemental oxygen. And 2 of them died on the flight, and they only reached 8,500 meters. So they missed it by about just under 1,000 meters. And there's a memorial in Paris to the 2 who died during that experiment. And then we have Dr. Hubertus Strugelhold, who was the father of aerospace medicine and worked at the U.S. Air Force School of Aerospace Medicine. And he wrote a paper called Atmospheric Equivalence back in the 50s. And he talked about different pressures. So he said at 16 kilometers, which is about 43,000, 45,000 feet, that there wasn't enough oxygen to supply the human, even if they were breathing 100% oxygen. And at 20 kilometers, actually just under 20 kilometers, the atmospheric pressure is 47 millimeters of mercury, which is the same as the tension of water. So water boils. It was an eye-opening experience for me when I was in the altitude chamber at Beale Air Force Base, where they fly the U-2s, and you're in your spacesuit, and they put a beaker of red-colored water in there, large beaker, and then they take you up in altitude to above 63,000 feet, and you're watching the water boil in there and thinking, I really hope this spacesuit doesn't get a hole in it because I'm going to be dead shortly. Um, he also said that at 33, they found that at 33,000 feet, 100% oxygen only gives the sea level equivalent of oxygen if you were at sea level, unless you started breathing under pressure. So many of the pressure breathing devices kick in at around 30,000 feet, and then you switch to pressure breathing about 43,000 feet. So enough of the history of this. Let's talk a little bit about the science. Hypoxia is a reduction of oxygen available at the tissue level for cellular respiration. So that means your muscles, your nerves, your brain, etc. For the pilot, it just means we don't have enough oxygen to fly safely. And there are 4 different types of hypoxia. There's hypemic hypoxia, which I alluded to earlier, and that is the carbon monoxide attaches to the hemoglobin molecule, so the blood can't carry the oxygen. The hemoglobin actually can't. There's histotoxic hypoxia, which the cells can't use the oxygen even though the blood can carry it. So alcohol would be one. There's a picture of someone with a little bit of cyanide poisoning there. Stagnant hypoxia is when you're pulling G's and all the blood doesn't get to the essential parts, particularly the brain. So sitting for a long time, you get that. Certainly pulling G's is the most common one. Low temperatures or shock, where your heart isn't pumping out the blood that it should, would be. But the one type of hypoxia we're mostly concerned with right now and affects us while we're flying is hypoxic hypoxia. Yes, that's written correctly. That's the right name. And it's a deficiency in the ability of the air to transmit oxygen to the blood through the lungs, through little sacs in the lungs called alveoli. Okay, and that comes from the reduced oxygen pressure that's available. And generally, there's 2 ways to do that. One is altitude. You go up in altitude, you have a lower total pressure. So the concentration of oxygen doesn't change. It's 21% in the atmosphere. It's just the pressure. So just rounding numbers, let's say that the atmospheric pressure is 1,000 millibars. It's slightly more than that. So 200 millibars of that would be oxygen, 210 millibars. So as you ascend and the pressure drops, let's say you go up to 18,000 feet, the pressure then would be 500 millibars, but the oxygen tension would only be 100 millibars. So we're looking at those same figures that Strughold showed earlier as a reduction in oxygen. So that's the primary way. And if you go to the FAA now, and even in the military, they use what's called ROBAR, reduced oxygen breathing devices, to do the altitude chamber training. So they don't change the altitude pressure. What they do is they change the gas mixture so that oxygen is replaced by nitrogen, and it simulates the effect of going to altitude. So those are the 2 different ways you can go through altitude chamber training. And if you go to an event where the FAA is training, or you make an appointment to go down to the FAA Civil Aeromedical Institute, you can actually get altitude chamber training. But if you go to an event like Oshkosh or Sun and Fun, The FAA brings its portable altitude chamber training, and I would highly recommend that for anyone who hasn't been through that training before. There are other causes for hypoxia, but most of these wouldn't be relevant while you're flying, because if you're having an asthma attack or you have pneumonia, you shouldn't be flying anyway. So the FARs talk about supplemental oxygen. It's part 91 211. And it talks, most of us know these rules, that above 14,000 feet is required for crew. Above 15,000, it's required to be made available for passengers. But the big one that we get into is between 12.5 and 14. If we if we are flying in between those altitudes, any more than 30 minutes between those altitudes requires oxygen. And I've asked this question to the FAA several times and got the answer every time the same way. This is not a situation where you can go up for 29 minutes between that altitude band and then drop down to 10,000 feet and reset the clock. It's total time during the flight. So if for more than 30 cumulative minutes, you're above 12.5 and below 14, you need oxygen just as if you were above 14. Okay. And there aren't too many pressurized gliders except for the folks in the Perland project. But if you did have one, or you have a pressurized aircraft, 9121 Bravo is the reference for that. So here's the oxygen saturation at different altitudes. So you see the hypoxia stages for the different altitudes I've listed on the left up to 10,000 feet. So us in Colorado, that's pretty common. I mean, that's just a standard aero tow there. We are a little bit hypoxic, but it doesn't really affect us that much. If we wanted to have that same level of oxygenation and we were breathing 100% oxygen by mask, then we could be at the altitude equivalent of 34 to 39. And if you use a pulse oximeter, and I'll show you a few a little bit later, your oxygen saturation would be between 90 and 98. At the altitude at Kelly Air Park, a normal oxygen saturation is about 93 to 94. Our airfield is at 7,000 feet. So that's density altitude, 7,000 feet, you would be about 93 to 94. Your body can compensate for reduced oxygen between 10 and 15 by increasing the respiratory rate, but you will see a drop in your oxygen saturation. So that's why the military, 10,000 feet, you're going on oxygen. Above that, so if you're flying, if we get up to 17.5, we need to absolutely make sure we're on oxygen and our system is working, because if it's not, our oxygen saturation is dropping substantially, and our ability to carry that oxygen to the tissues, and in particular the brain, is compromised. And I'll show that in a following slide. And then if you were to 20 to 25,000 feet, you're at critical hypoxia. So you think about those people climbing Mount Everest at 29,000 feet and going without oxygen. Well, they've spent 3 to 4 weeks acclimatizing to that and changing the physiology, particularly the kidneys, and their ability for their hemoglobin to carry oxygen. But still, people die trying that. So remember from Struckehold, we talked about, actually it was Paul Bear who said the 45 was the limit for oxygen and functioning normally, the oxygen tension and functioning normally. So that happens at about 15,000 feet. You can see the O2 sat has dropped to about 80%. And again, normal at our altitude is about 93 to 94, our altitude being 7,000 feet at Kelly. Don't need to really know this other than my example about the folks climbing Mount Everest. The oxygen carrying capacity shifts significantly with the pH, or the acidity, alkalinity of the blood, and how quickly it can release the oxygen. So it's your kidneys that are actually adjusting this along with your respiratory rate with hyperventilation acutely and your kidneys chronically that change the oxygen carrying capacity of the blood. Another diagram showing. So what's important here, and if you can see my mouse, through about the oxygen tension can drop off fairly significantly down here, but the oxygen saturation stays normal till about 90, and then it starts dropping off precipitously. Okay, so remember I said that at 10,000 feet, your O2 saturation is about 90, and then beyond that, it drops. My mouse disappeared. There it is. The O2 saturation drops off precipitously. So what are some of the effects of hypoxia here? One, you get the impaired judgment, may get a sense of breathlessness or increased respiratory rate. Some people will get anxious, particularly if it's an acute onset of that. Dizziness and fatigue, blurred vision, or flushing will be some of the things that you can feel. Some of the things that also will be somewhat subjective, headache, the euphoria. My personal symptom of hypoxia is that I get a warm flush feeling on my face. I start to feel hot, and then I start to laugh a little bit. And then when I think about it, I get the tingling. But if you've gone through altitude chamber training, you fairly consistently will have the same symptoms each time you're exposed. So I've done it probably 24 times, and very consistently I get that. So for you who haven't done the oxygen or the hypoxia training, I would highly recommend that you do that so you can recognize your symptoms when you're going up. More objective type symptoms or signs, more specifically, would be increased respiratory rate, deep breathing, cyanosis, so blue skin. The tingling I talked about was really related to hyperventilation. You're increasing your breathing rate. So just going back one slide, I put tingling on there. You're breathing faster to compensate for the lower oxygen, and you're driving your carbon dioxide levels down. And that's what gives you the tingling in your fingers. The blueness in your fingers and your lips, if you can see it, is due to cyanosis or the lack of oxygen in those tissues. Your heart rate increases to compensate for that. And then we look at effective performance time and time of useful consciousness as people get hypoxic. And this is also demonstrated in the altitude chambers or the Robard devices when you're going up. But you still may be conscious, but you can't perform effectively. You can't do a checklist, or you can't run a procedure that you would normally do. And those drop off exponentially with increase in altitude, particularly above 18,000 feet. So distinguishing hypoxia versus hyperventilation, fairly important. Hypoxia is low oxygen as opposed to hyperventilation, which is low carbon dioxide. You might be aware of your hyperventilation because of your increased breathing rate, but people who are hypoxic generally are not aware of that. Hypoxia will stimulate respiration, but if you're breathing fast and blowing off carbon dioxide, it suppresses your respiratory drive. So they're counteracting each other in a protective way. Again, we're talking about distinguishing between hypoxia and hyperventilation. The cyanosis is the blueness of your lips, or fingertips, or earlobes, if you can see them, as opposed to the tingling that you get in those same areas from hyperventilation. So this is real important when you're flying. If you are hyperventilating, you want to slow down your breathing. If you're a hypoxic, well, you will increase your breathing, but you need more oxygen, you need to descend. The hyperventilation is more characterized by an anxiety type response versus an impaired and unawareness of your cognition deterioration in hypoxia. Both can result in loss of consciousness, but the treatment for each, for hypoxia, is get on oxygen as high levels as you can and descend. But for hyperventilation, it's to slow your breathing and you can rebreathe. So that's the old breathing into a bag too, or put your hand semi-covering your mouth and try to breathe like that. Two different treatments, frequently confused with each other. Each can happen independently, although hyperventilation usually goes along with hypoxia. You don't necessarily have to be hypoxic to hyperventilate, particularly if you're in a stressful situation. So these are the factors that go along with that. The altitude, the duration of exposure, the longer you're at altitude, assuming you're not acclimatizing to that, increases the risk of hypoxia. A faster rate of descent will increase hypoxia. Your fitness and health, people who may have heart disease or taking certain medications or may have asthma or smoking, certainly those people are more prone to the effects of hypoxia at earlier times. Toxic exposures, probably the most common one that we would have would be cigarettes. Physical exertion, you're using up your oxygen more quickly. Generally, we're not doing a lot of physical exertion while we're in the glider, but that is another factor. Climatization, those of us who live in Colorado and stay at this altitude have our kidneys change the pH, the natural pH in our blood so that we do have better oxygen carrying and offloading ability. And then training too, particularly when it comes to hyperventilation, making sure that you can handle the emergency situations well, that you can recognize these well, and that you can treat each symptom appropriately. So here's a picture of the Perland folks. How do we prevent hypoxia? Well, we can pressurize the aircraft, not an option for most of us. But for most of us, we do have supplemental oxygen. Almost everyone in our club has oxygen carrying capacity, and there's different types. There's pulse demand, where you inhale and you get a fixed amount of oxygen from a source. Continuous flow tends to burn up a lot of oxygen, but you're getting oxygen on a steady basis. Diluter demand changes the amount of oxygen you're getting depending on the altitude you're at, and so it's sensing barometric pressure. And pressurized oxygen, more for people who are flying very, very high altitudes and use appropriate ceiling face masks. But we can also monitor it too. So the monitoring system, really, I just use one example. Many of us use the EDS system for Mountain High. And it is a variable pulse demand system, which allows you to conserve oxygen there. And it has 8 different flow settings. I'll go over that. There was testing by the FAA on this system, and nasal cannulas are approved through 18,000 feet, and a face mask with a rebreathing device is approved through 25,000 feet. And generally, with use of that, it should keep your oxygen saturations 97% or better. If you go to the Mountain High website, they have the FAA technical report on this. But remember, at 7,000 feet, our oxygen saturation is about 93 to 94. So these are the 8 settings on the EDS. Nighttime or now is how they describe it. Gives oxygen at any altitude, but dilutes depending on the altitude. The day or delayed starts at 5,000 feet. I think for those of us in Colorado, most of us will use a D10 setting. And that starts activating the system and giving you puffs of air at 10,000 feet, and it senses the altitude and gives you different doses of that. And then the face mask settings, most of us are not using a face mask, but they are very, very similar to what the nasal cannula ones are. And then the emergency one, if you were to get any hypoxic symptoms, you go to the reserve manual mode and it maximizes the flow regardless of what altitude you are. So my personal technique is I use the D10. I put the cannula on before flying. I don't try to put it on when I'm flying. Set it to D10, make sure I test it on the ground before I go up. And then it kicks in at 10. It has an apnea alert, or if you're not breathing, it alerts you. And then if I've been flying for a while and I'm descending below 10, um, I will go to usually the D5 or N for about 3 to 5 minutes before I land, just so that I'm um, maximizing um, my opportunity to function as well as I possibly can cognitively during that critical phase of flight. So that is a balance between conserving oxygen when I'm flying, so I have enough to complete a longer flight, and making sure that I'm using plenty of oxygen before I enter my final critical stage of flying. We also have a pulse oximeter you can fly with. It looks at your oxygen saturation. Ideally, it should be over 90%. Ideally, it should be as high as possible. But again, at our altitude, just breathing ambient air, we're about 93%. On this device, it's showing a pulse rate of 74 and an oxygen saturation of 97. Some have alarms if you're doing it, but if you're hyperventilating, it doesn't work very well. Okay. It indicates that you're going higher. So you want to make sure you're not hyperventilating. The other problem is that cold fingers, because it's sensing a colorimetric change in the skin, cold fingers will give lower readings than are what are accurate. So if you're using the finger pulse oximeter intermittently, you may want to warm your hands when you're doing it. A lot of the smartwatches now will have wrist ones, which function, they're not as susceptible to the cold errors that would be generated for that. And so, I have one watch I can use when I'm flying that I switch between time and oxygen saturation. I have a link down there to the World Health Organization pulse oximetry training manual, which was pretty good. And you can get these devices on Amazon for a variety of prices. From my review, the price doesn't have a linear relationship with the quality. So if you're using one, you're better off than not using any, and you don't have to break the piggy bank on it. So in the military, we used a price check. And I would recommend doing this prior to taking off and also while you're flying. So I check the pressure in the cylinder using the remote gauge, make sure that it's open. I check the regulator that the EDS is setting. So I check it on the ground and make sure that it'll flow. The lights and alarms and the EDS, they're fairly automatic there, but know your signals, what one beep means, what two beep means, what three beeps mean, and do that. Make sure your connections are appropriate, but fortunately the EES will give you an alarm if it's not flowing there. But make sure during flight that you're not, your tubes aren't in a situation where they're crimping or that you're sitting on them or they're compressed. And you can test the emergency flow. So we did it in the military. That would be the equivalent of the reserve manual mode on the EDS. So I'm not going to spend a lot of time on these hypoxic accidents, but there's one from Boulder that I will talk about a little bit more. But the NTSB found this one in Minden where they were trying to do wave flights. The probable causes, the pilot incapacitation due to hypoxia. Okay. And people saw the glider break up in flight on the descent there too. This was in Truckee, so right north of right north of there, hypoxic and attempted to land. During the landing, he overshot the airfield. Um, he was up for 4 hours at that altitude. So this goes back to why I turned the oxygen on to the nighttime mode before I land, just so I get a good dose of oxygen like that. But he thought he was chronically hypoxic and possibly due to he was breathing through his mouth. But fortunately, the EDS systems do give you a warning if you're mouth breathing on that. This was a duration flight, high altitude and duration flight in Hawaii. But basically, the person was trying to use two systems. He used a diluter demand system, but wasn't working as advertised and didn't use it. He didn't set it at the normal setting and it was above that level that that normally you require pressurized oxygen. Remember, 33,000 feet require pressurized oxygen to get the same oxygen equivalent at sea level. And if he was in Hawaii, he was spending most of his time at sea level. Showed he went up to 38,000 feet, so definitely needed pressurized oxygen from the A14. And I won't go through all of that. You all can take a look at this when you have the PDF file of it. But I think the important part of this was the pilot wasn't trained to recognize his hypoxia symptoms. So again, another plea for you to go through the hypoxia training that's available through the FAA or those who have had the opportunity to do it in the military. That's great. And here are some publications from the Civil Aviation Medical Institute on hypoxia, written by Tom Nessus, who's really good in fatigue as well. And here's some other resources. Brent Blue has a great thing about pulse oximetry. And here's some other references. Dan Johnson had a nice article too in Soaring magazine if you want to go back about 15 years. Okay. And of course, the FAA has a safety brochure on that. And here are some more of their safety brochures related to hypoxia, oxygen equipment, and decompression sickness. Just a brief word about decompression sickness. Generally, we're not going up from sea level to the altitudes we're flying. If you are flying in a contest that we're at sea level, it's a potential factor, but the biggest risk is someone who goes scuba diving beforehand within 24 hours. If you shouldn't go scuba diving within 24 hours of flying to altitude. And if you have decompression stops, generally recommend at least one extra day for each decompression stop that you have to take on the way up to avoid the nitrogen washout from that and potential decompression sickness. So my bottom line recommendations of this: use oxygen anytime you're going above 10,000 feet. Make sure you filled the bottle beforehand. You have batteries in your EDS. Do that price check that I talked about. Pulse oximetry is a good check, either the wrist one, if you're not, or a finger one if you're not cold and you're not hyperventilating. But if in doubt, if you're unsure whether you're hypoxic or hyperventilation, safest thing is to descend immediately and get the oxygen that you have available on board. I'll talk briefly about fatigue here a little bit, and that's from a previous one. But we've already talked a little bit about, I've talked a lot about fatigue already. So I may go through this rather quickly. But these are from the Airman Information Manual about that and from the FAA safety brochure on fatigue. And I apologize, I rated the cookie jar a little bit earlier in the talk on this, so some of it may be repetitive. So because of that, I'll go through it a little more quickly so we have time for Q&A afterwards. But just like intoxication, we're our worst judges of our own fatigue. And we really can't detect or or accurately characterize our degree of fatigue or impairment due to fatigue when we are tired, unless you're really tired, and then you know. So we've already talked about the different types of fatigue, short ones that come from 1 to 2 days, cumulative fatigue, and circadian fatigue in the window of circadian low. If you had to function between 2 and 6 a.m., but that's not relevant to most of us glider pilots who are flying around here. We don't fly during those hours unless we've made a transcontinental trip and we're flying earlier. But generally, that's not a problem. With circadian issues, we have 2 periods of circadian low, usually in the very, very early morning hours and a little bit in the mid-afternoon as well, siesta time. Our natural circadian rhythm is about 25 hours, but there are normal physiologic variances among the population, and that is affected by our darkness or light in the early morning will help adjust to that. Melatonin that's produced by the body or taken exogenously, and adenosine, which is the chemical that accumulates in the body with total time awake and is blocked. It causes sleep drive, but it's blocked by caffeine. And then exercise can also affect circadian rhythms and help reset the clock. So there are a lot of things that your circadian rhythm affects, and we think about sleep cycle too. But also, when you look at different accident studies, memory, critical thought, and reaction time in an individual who has been sleeping normally but has to function during periods of circadian low is substantially impacted. And the amount of accidents that happen during periods of circadian low go up almost proportionally with subjective feelings of sleepiness during that period. But also it affects your digestion, your bowel habits on that, and your blood pressure fluctuates with circadian. So let's talk briefly about sleep. There are really 5 phases of sleep. 1 and 2 are the light sleep. 1 is just preparing for sleep. 2 is you're actually in light sleep. So in 1, your blood pressure is reduced, your heart rate is reduced, your breathing rate is reduced, and your body temperature starts to go down. But there's not a whole lot of benefit during that period of time, with one exception. Stage 3 and 4 are deep sleep. These are characterized by electroencephalographic changes, EEG changes, and it shows slow waves in there. But this is the area where you get the memory, the learning, and physical rehab. With REM sleep, your brain is actually awake. The EEG looks almost like an awake individual, but you're not moving because a certain chemical called acetylcholine is not released to the peripheral body. So you don't have movement during this period of time. So you're not acting out your dreams. But this is where you get the emotional recovery and a lot of the learning. The procedural memory really happens in stage 3 and 4, and the declarative memory, so the ability to repeat facts, but synthesizing all of that into a learning experience happens during the REM phase. So if you're not getting REM sleep, you're not learning. So this is a chart of people who are sleeping, and the red up here is the important part, and this is increasing REM sleep with each sleep cycle. So each sleep cycle is about 90 minutes. And so we normally will go through 4 to 5 sleep cycles with a normal 8-hour rest period. But what you see is in the earlier phases are characterized by deep sleep. And this is where you get the physical restoration. So you can feel physically better during this period of time with a limited amount of sleep. But you're not getting the majority, the overwhelming majority of your REM sleep until you get into the later phases of sleep. So if you're not sleeping 7 hours, you're losing at least half, if not more, the opportunity for the learning, the memory, the emotional processing. People who don't get REM sleep after a traumatic event are much more susceptible for PTSD. and the issues of healing from emotionally challenging events. I won't even say traumatic events. They looked at the lifespan of rats, and they've also looked at lifespan of individuals, but couldn't do this study. Rats who are given normal sleep live 2 to 3 years. If they're deprived of their REM sleep, their lifespan goes down to about 5 weeks, and if they're totally sleep deprived, goes down to about 2 weeks. In humans, we found that increased sleep periods of time are directly related to longevity and some mortality. So there are a lot of different factors. I've already talked about most of these factors associated with sleep, but normally 7 to 9 hours is really what we think about as needing it. And those of us who told ourselves in earlier parts of our lives that we could function on less, we're really just kidding ourselves and functioning at a low level. Folks with obstructive sleep apnea are waking up all the time and not getting into REM sleep, and they have cognitive impairment until they're treated. So the pilots I talk to who we assist with getting FAA clearances for their obstructive sleep apnea say frequently, I never knew I felt so bad until now I'm treated and I feel so good. Their baseline was poor and they just never realized that. I never would have pulled an all-nighter in college knowing what I know now about sleep because I was just wasting my time. There are lots of other factors that can impair your sleep. So I've just listed a few of those. And I've already mentioned sleep apnea. Sleep apnea in adult males is about 7% of the US population. The numbers vary a little bit, slightly lower in females, but there are some very severe medical consequences with it. Increased blood pressure that requires multiple medications to do about a 3 to 4 times increased risk of stroke and heart disease. It's associated with depression, with cardiac arrhythmias such as atrial fibrillation, such that if the FAA notices someone that has atrial fibrillation, requires a sleep study because the association is so strong. And in many cases, you can, treating sleep apnea, you can reduce the blood pressure medicine, see cognitive improvement, and reduce the risk of other diseases. So these are other contributing factors to fatigue. We've already talked about a lot of these. Things we don't think about is chronic diseases. Arthritis, chronic pain disturbs sleep and takes away from the ability to get that REM sleep if you're not sleeping continuously. And so that can cause fatigue and cognitive function. Certainly there are medications that affect that in certain medical conditions. Environmentally, we're at risk as sailplane pilots because we're in a very dry environment. We're in a hot environment. We have a lot of insensible fluid losses because of our dry environment, so we get dehydrated easily. Hypoxia contributes to fatigue. Bright lighting, if you're flying into the sun all the time, we don't fly gliders at night, except in rare situations, but that can do it. Hot temperatures will increase fatigue. Comfort in the cockpit, making sure you're not sitting on your wallet, that everything fits well. Making sure your nutrition, so you have adequate but not excessive sugars and hydration. Noise is not usually a problem in gliders. Vibration and turbulence, hopefully not a continuous problem, but for people who fly helicopters, things like that, it's a big problem and contributes to fatigue. So I'll just summarize this one slide. For people who are fatigued for 3 to 4 days, so miss 8 hours of sleep, we know that their recovery time is longer than 3 to 5 days, and it's shorter than 24 days, but we don't know where it falls in between. But if you think that you can just recover in 1 day by sleeping 10 hours, you're fooling yourself on that. And so this was Dr. Lamp from the University of Washington did some great studies on this, and so I've listed various conditions that go along with acute fatigue and sleep deprivation. Also, there were several other studies. John Caldwell down there was one who's a very prominent sleep expert or fatigue expert too, where Sarah Lamp is the sleep expert. But these are all things that have a negative effect on safety when we're flying. And here are the symptoms we might experience while we're in the air. So decreased alertness is probably the most dangerous one that we have there. But you can look at all of those. And when I say dangerous, one, it could be hazardous, but two, it can make you not fly in the optimal way, such as poor thermaling technique, not being able to hold your speed to fly. And here are some of the symptoms. I apologize, I'm going a little bit fast or a lot fast because I want to make sure that there are time for questions, answers. Let me just ask a question. Has anyone, a rhetorical question, has anyone been driving down the highway at night and realized that they've just gone past 3 or 4 exits they don't remember? They're actually going to sleep. The body, when it's sleep deprived, will actually have periods of sleep where you're not awake and you are not awake, but your eyes may be open. But you are actually asleep during these periods of time, and they can last for up to 20 seconds. So these are certainly very, very dangerous, but you can get microsleeps during the day too if you're sleep deprived. So what are good strategies to mitigate against fatigue for the pilot? 2 good nights of sleep before you fly, 8 hours time. Avoid the medications that would depress your cognition. Avoid alcohol so you get the REM sleep. The question earlier today about staying cool is also relevant to minimizing your pre-flight physical exertion, so assembling your glider beforehand. All that. Wearing sunglasses so you're not getting the bright light in your eyes. Again, reducing the heat both on the ground and in the air. You can use neck and head cooling or palm cooling, although that's not practical. And if you're going to be flying at high altitude for a long period of time, make sure that you're dressed appropriately so you don't you don't consume too much energy while you're up there flying, which can also contribute to fatigue. And of course, smoking causes reduced oxygen carrying capacity, which causes hypoxia, which causes fatigue. So what can you do to try to stay awake? You can consider caffeine during a period of time. It has onset of about 15 minutes to a half hour until it kicks in. As far as eating, as I already said, frequent small amounts. Use the proteins and complex carbohydrates. Don't use the simple sugars or the sweets. And make sure you still stay well hydrated. Have your cockpit nice and comfortable. And we've talked about all of these systems already. And for the oxygen, make sure that you have your oxygen working. If you're getting tired, monitor radio, make a call. And then you can take a nap before flying. You're not getting the cognitive aspects of it, but you're getting some of the physical. But if you are going to take a nap, limit it to between 25 and 40 minutes. You don't want to get into a deep sleep where you have sleep inertia, and it takes between 30 and 60 minutes to get full cognitive function. Also, to prevent deep venous thrombosis, particularly if you're taking a long flight, make sure you're flexing your ankles, contracting your calves too. Drugs, I think I've talked about most of these already. Big thing is diphenhydramine, not within 60 hours of any flights that you're doing. And these are operational things you can do to mitigate fatigue. Plan the flight beforehand. Make sure you have adequate people to help you get the glider out on the line. Follow your checklist. We've already talked about staying cool and pre-assembling the glider beforehand. Getting under, this was the question that one of you gentlemen asked beforehand, staying in the shaded area and using a relief system. So these are some resources that are there. Again, these will be in the slides that you'll have access to after they're posted. So in summary, we're all human. We all have physiology. We're not superhuman, so don't try to fool your physiology. But you can use physiology, diet, nutrition, exercise, oxygen, etc., to maximize your performance. Most drugs will hurt, but a few can help with that. Plan everything you can beforehand, both not only for your flight, but for your individual person, and making sure that you're the best possible human you can be before you take the flight. So with that, I think I'll conclude. I have just a few minutes for questions, but happy to stay on as long as people would like to answer questions. So Alice, can you open it up for them?
Yes, we just have a few here. Adrian asks, is an oxygen concentrator, such as the Inogen Rove 6, an adequate oxygen supply for gliding? Is it supposed to be, it is supposed to be good to 18,000 feet?
Adrian, I'm sorry, I can't answer that question. Um, I don't know the answer. Um, uh, Whether it's been tested, you say it's supposed to be good up to 18,000 feet. I think the practical consideration is how do you fit it in a glider? Um, but I try to only use things that are approved by the FAA and tested. So I apologize. That's the best answer I can give you.
Okay, and this next one, you touched on the testing of the cannulas and the approval with the FAA, but I'll give you this question anyway in case you have any further thoughts on it. Do you consider that the nasal cannulas that we use function adequately when we're up above 17,000 feet? Is there any loss of effectiveness?
So not a loss of effectiveness as far as how they function physically or operationally, but you're not, the mountain high system is certified up to 18,000 feet. So the question was 17,000. As long as you have it set for D10, it should give you adequate oxygenation, adequate being with an oxygen saturation level of 90% or better. However, if you have any doubts, you can always use the face mask with the rebreathing, which has been cleared up to 25,000 feet, but that gives you a margin of safety. In the context we're talking about, you can't get too much oxygen. So I use a nasal cannula up to 17,999.
Okay, thank you, Quay. Getting kudos for a great presentation. We really appreciate your time and expertise. And that's it for questions now. Oh, yep. Thank you. Another
Well,
thank you come in.
thank you very much. I appreciate everyone staying awake long enough to endure this talk. But please fly safely, and if you have any questions, you can relay them through, and I'll be happy to answer them for each of you. So thank you very much, and fly safely.
Thanks, Quay. Thanks, everyone.